So good morning everyone. Today we will discuss one of the complications that we encounter in pregnancy, that is hypertensive disorders in pregnancy. So basically we will start with how to measure the blood pressure and how do we classify hypertensive disorders in pregnancy and what is the etiology behind these specific condition and what are the risk markers for developing hypertension during pregnancy and what is the pathophysiology of this condition and are there any predictive tests or any preventive strategies for preventing this complication during pregnancy and what are the various complications with this condition, both maternal and fetal, and even some of the complications tend to persist even beyond the pregnancy. So what are the long-term adverse effects of this condition and how do we manage? So once this condition is diagnosed, what should be our antepartum, intrapartum and the postpartum management? So we shall start with how to measure blood pressure. So there are few guidelines how to measure blood pressure. So always we need to use an accurate equipment, that is most important. So preferably a mercury sphygmomanometer or a validated alternative method, and the position of the patient should be either sitting or, in case if she is in a supine position, preferably in the left lateral position with a 30-degree tilt and with this instrument at the level of the heart. So always the instrument should be at the level of the heart. And another thing is never take the blood pressure in the upper arm with the woman on her side, so as this will give false lower readings. And at any point in pregnancy, the absolute level is the best guide to fetal and maternal prognosis, and we usually adopt a pressure of 140 by 90 as the cutoff. So beyond which or above which usually it is associated with maternal and fetal morbidity and mortality. So this is the cutoff level that we usually adopt in pregnancy. And so we need to always use an appropriate cuff size. So the standard cuff size being 13 by 23 centimeters for an arm circumference up to 33 centimeters. And in case if the arm circumference is between 33 and 41 centimeters, a large size, that is 33 by 15 centimeters cuff should be used. And in case if a woman is obese or if the arm circumference is more than 41 centimeters, thigh cuff has to be used, that is 18 by 36 centimeters. And in 15% of pregnant women, so usually the diastolic blood pressure falls to zero or is zero, so before the last sound is heard. So in these cases, we need to usually record both the phase 4 and phase 5, and it should be recorded in this way. And we need to measure to the nearest 2 millimeters mercury to avoid digit preference, and obtain an estimated systolic pressure by palpatory method to avoid an auscultatory gap. And deflate the cuff slowly at a rate of 2 to 3 millimeters per mercury per second, taking at least 30 seconds to complete the whole deflation. And in pregnancy, we usually use cord cuff 5 for measuring the diastolic blood pressure. See, cord cuff 5 is nothing but the disappearance of the heart sounds. So we usually take this cord cuff 5 for measuring the diastolic blood pressure because this is subjected to less intra-observer as well as inter-observer variation when compared with the cord cuff 5, that is usually the muffling of heart sounds. And also cord cuff 5 also correlates best with the intra-arterial pressure in pregnancy. So mostly it is the cord cuff 5 what we consider for measuring the diastolic blood pressure, not cord cuff 4, and because the thing is It is subject to less intra-observer as well as inter-observer variation, and it correlates best with the intra-arterial pressure in pregnancy. And before we move on to the classification of hypertensive disorders in pregnancy, we see what is the variation of the blood pressure that we usually see in pregnancy. So usually the blood pressure tends to fall in the second trimester. So if you see this graph, so usually the blood pressure tends to fall from the first trimester, it falls in the second trimester, and it tries to again go up in the third trimester. So this is the normal trend that we usually see in a pregnancy. And coming to the proteinuria, so this is also one of the diagnosis apart from hypertension. If a woman has a significant proteinuria, then we label that a woman has a pre-eclampsia. So when do we say that a woman has proteinuria? So significant proteinuria is the urinary protein creatinine ratio of greater than 30 milligrams per millimole, or else a validated 24-hour urine collection if it is more than 300 milligrams protein. So this is considered to be a significant proteinuria in pregnancy. So now we move on to the classification of hypertensive disorders in pregnancy. So we have gestational hypertension. It is gestation is pregnancy. So gestational hypertension is the blood pressure of equal to or more than 140/90 that is seen during pregnancy but without proteinuria, and usually this blood pressure returns to normal within 12 weeks postpartum. So then only we should label this as a gestational hypertension. Whereas pre-eclampsia is characterized by a blood pressure of equal to or more than 140/90, and this is recorded for the first time after 20 weeks of gestation. So that is most important. So it is always after 20 weeks of gestation, and also one of the criteria being, so this high blood pressure should be recorded on at least 2 occasions 4 hours apart, and this should be associated with proteinuria. So then we say that a woman is having pre-eclampsia. So one is the blood pressure, and then 2, it should be recorded for the first time after 20 weeks, and then we need to have always 2 recordings of high blood pressure 4 hours apart, and it should be associated with proteinuria. So that is pre-eclampsia. So in gestation hypertension, it is only the hypertension, whereas in pre-eclampsia it is apart from hypertension, we need to even have proteinuria as an associated condition. And coming to eclampsia, so it is nothing but the occurrence of convulsions or coma in a woman with pre-eclampsia, which is not attributed to other causes of seizures. So sometimes the causes of seizures could be anything. So it should not be because of the other causes. So it should be exclusive in relation to pre-eclampsia. So convulsions or coma occurring in a woman with pre-eclampsia not attributed to other causes. And we have another entity called chronic hypertension. So this is nothing but the woman has already pre-existing hypertension so before pregnancy, or if the hypertension is detected before 20 weeks, and that too it should not be attributed to the trophoblastic diseases like monarch pregnancy. So if a woman has already a pre-existing hypertension, or if the hypertension is detected before 20 weeks, we label it as a chronic hypertension. And there is a superimposed pre-eclampsia as well. So here the pre-eclampsia is superimposed on chronic hypertension. So in a woman with chronic hypertension, so this pre-eclampsia will be superimposed maybe in the second trimester or the third trimester. So that is superimposed pre-eclampsia. So this is how we classify hypertensive disorders in pregnancy. So at the one end we have only hypertension seen only during pregnancy, which reverses back to normal within 12 weeks. And then we have pre-eclampsia with hypertension with proteinuria, we have eclampsia, and then chronic hypertension and superimposed pre-eclampsia. And then we need to even know 2 other entities called early onset pre-eclampsia. So if your pre-eclampsia develops before 34 weeks of gestation, we call it as early onset. So usually this pre-eclampsia tends to occur towards late second trimester or in the third trimester. So if it is, the onset is before 34 weeks, we call it as an early onset pre-eclampsia. And there is another quantity called imminent eclampsia. So this is nothing but occurrence of signs and symptoms in a woman diagnosed with pre-eclampsia, and these signs and symptoms indicate that the seizures or the convulsions are impending or imminent. So usually we consider symptoms and signs like headache, nausea, vomiting, and blurring of vision, oliguria, and epigastric or right upper quadrant pain, or brisk deep tendon reflexes. So in a woman already diagnosed with preeclampsia, and if she has any of these signs and symptoms, we call it as imminent eclampsia, because these signs and symptoms indicate that the woman might throw a convulsion or a seizure. So at every visit in a woman diagnosed with preeclampsia or hypertension, we need to always inquire whether she has any of these signs and symptoms which indicate that eclampsia is impending or imminent. So coming to the features of preeclampsia, so we usually broadly divide into non-severe preeclampsia and a severe preeclampsia. So one of the criteria is the blood pressure. So if it is more than or equal to 140/90 but less than 160/2, it is non-severe, whereas if it is above that, it is severe preeclampsia. And usually the proteinuria tends to be less than 22 plus in the bloodstream, and if it is more than that, or if it is more than 5 grams in 24 hours, it is severe preeclampsia. And usually we don't see any of these signs and symptoms in cases of non-severe preeclampsia, whereas in a woman with severe preeclampsia, all those imminent signs and symptoms will usually be seen. And if we do investigations, usually these tend to be normal in cases of non-severe, whereas there can be altered levels in the investigations in the form of thrombocytopenia or elevated liver enzymes or rising serum creatinine in cases of severe PE. And when it comes to fetal status, usually we don't encounter see any fetal growth restriction in non-severe, whereas fetal growth restriction may be present in cases of severe preeclampsia. So to again define preeclampsia, so it is nothing but the hypertension accompanied by one or more of the following new onset conditions after 20 weeks, and of course with proteinuria. So the maternal organ dysfunction can be in the form of an acute kidney injury. So usually we see that the creatinine is equal to or more than 90 micromoles per liter, and the liver enzymes tend to be elevated. So especially the transaminases more than 40, and the symptoms may or may not be present. So that is the right upper quadrant pain or the epigastric pain may or may not be present, but usually there can be a rising elevated transaminases. And neurological complications can also be seen, like in the form of eclampsia or coma or severe headache or even visual disturbances. And in the hematology, we may see there is thrombocytopenia, that is the platelet count less than 1.5 lakhs, or hemolysis. And there can be even atrio-placental dysfunction, which is usually seen as a fetal growth restricted baby, or when we do a Doppler velocimetry, there can be abnormal values in the Doppler waveform analysis, or sometimes even a stillbirth is seen. So any of this maternal organ dysfunction can be seen in cases of preeclampsia. So the criteria for preeclampsia is, it's not only a hypertension, it can be even any maternal organ dysfunction, like any kidney involvement or liver involvement or neurological or hematological. And coming to the etiology, so why some of these women tend to develop this complication during pregnancy? So it is usually a combination of impaired trophoblast differentiation and invasion during the first trimester of pregnancy. So there is the failure of trophoblastic cells to destroy the muscularis layer of the spiral arterioles, so ultimately causing development of a poorly perfused placenta. So it is a combination of, one is the impaired trophoblast differentiation. So the trophoblastic remodeling is lacking. So there is impaired trophoblastic differentiation at one end, and the failure of these trophoblastic cells to destroy or invade the vascularis layer of the spiral arterioles, so thereby leading to a placenta which is evenly perfused. And in pre-eclampsia, the invasion of the uterine spiral arterioles is limited to the proximal residuum, with 30 to 50% of the spiral arterioles of the placental bed escaping this endovascular trophoblast remodeling. So almost half of these spiral arteries escape this endovascular trophoblast remodeling, which is otherwise usually seen in a normal pregnancy. So in a normal pregnancy, we see this endovascular trophoblast remodeling, whereas in pre-eclampsia, this is lacking, ultimately leading to utero-placental dysfunction. So this prevents the normal physiological adaptation of the spiral arteries to pregnancy and leads to a reduction in blood flow to the intervillous space, as well as both placental hypoxemia and ischemia. So ultimately it leads to utero-placental dysfunction or hypoxia. So this is this slide shows that there is impaired vascular transformation resulting in impaired utero-placental perfusion. So in a normal pregnancy, usually we find or we see that there is disruption and loss of the vascular smooth vessel layer, and the endothelial cells are usually replaced with the endovascular extravenous trophoblast. So this is considered to be normal in pregnancy. So the endothelial cells are usually replaced with the endovascular extravenous trophoblast. So this remodeling is usually essential in pregnancy, and there is loss of vasocontractility, and the spiral arterioles are dilated so that there is increased blood flow to the intervillous space. So this is what we usually see in a normal pregnancy. Whereas in pre-eclampsia and fetal growth restricted babies, so there is failure of this remodeling mechanism. So we can clearly see in this slide that in the right half, so usually there is failure of the endovascular trophoblast remodeling. So the invasion of by the endovascular trophoblast or the extravenous trophoblast is lacking, and there is retention of vasocontractility property of these arteries, and so that there is insufficient and pulsatile blood flow to the intervillous space. So ultimately resulting in an inadequate utero-placental perfusion, leading to hypoxia and ischemia. So there is lack of proper maternal and fetal exchange. So this is the one thing that we see in pre-eclampsia. So I hope it is clear. So what is happening in normal pregnancy and what is happening in pre-eclampsia. So there is a failure of this remodeling mechanism in pre-eclampsia, leading to inadequate utero-placental perfusion, ultimately leading to the improper maternal and fetal exchange. So it is not only the defective extravenous trophoblast invasion causing the venous ischemia that we have just seen. So even the maternal constitutional factors like obesity or genetic factors or diabetes. So even these factors usually play in the development of pre-eclampsia and the associated complications. So apart from the defective extravenous trophoblast invasion that we see in this condition, so the other contributing factors are the maternal constitutional factors, like the mother might be obese or the mother might be already hypertensive or over diabetic, or sometimes even genetic factors are also seen. So this condition is usually seen in women where there is a positive family history of pre-eclampsia, or in women already having previous pre-eclampsia in previous pregnancies. So even genetic factors also tend to play a role in the development of this pre-eclampsia. And also the one more additional factor contributing to the various manifestations of preeclampsia is in the placenta. Usually we find there is release of both pro-angiogenic and anti-angiogenic factors. So in preeclampsia there is an altered ratio or altered release of this pro-angiogenic and anti-angiogenic factors, and also there will be release of inflammatory mediators, ultimately causing hypoxia within the placenta. So all these together, all these factors. So one is the defective endovascular trophoblast invasion or remodeling. The other thing is the genetic factors. The other factor being the maternal constitutional factors, and together with the placental release or imbalance between the pro and anti-angiogenic factors. So all these together play in the various manifestations of this condition. So at one end, we see the woman is hypertensive, and because of this placental release of these various factors, and because of the release of the inflammatory mediators, we find there is vascular endothelial dysfunction. So this contributes to the various systemic manifestations that we see in this condition. So even vascular factors, of course, also play. So the reduced production of nitric oxide results in the impaired endothelial cell integrity and causing leakage in the capillaries. So various manifestations that we see with this pre-eclampsia is because of the vascular endothelial cell damage and because of the leaky capillaries. So the fluid tries to come out of these vessels. So these are labeled as leaky capillaries. So the reduced nitric oxide results in impaired endothelial cell integrity, causing leakage from the capillaries. So this is also one of the contributing factor. So I hope I am done with the etiology. So coming into the various risk markers for pre-eclampsia. So broadly we divide these risk markers into some factors based on the demographics and the family history, and certain factors because of women's past medical or obstetric history, and few of the conditions that we encountered either in the first trimester or late trimester. So in the demographics and family history, so if a woman's age is equal to or more than 40 years, she is more prone. And also if she has a family history of pre-eclampsia, so if her mother or a sister has this condition, again she is at risk. And even the family history of early onset cardiovascular disease is also important. So we very well know that the maternal age above 40 years and family history of pre-eclampsia in the mother or siblings is important, but even the family history of early onset cardiovascular disease is important. So whenever you try to take history, you need to always try to elicit the family history of early onset cardiovascular disease. And coming to her past medical or obstetric history, so if she's a second gravida or a multi-gravida, always inquire whether she had any previous pre-eclampsia. So because it tends to be an important risk marker for developing this condition again in the present pregnancy. And also the other condition which is important is the antiphospholipid antibody syndrome. And also if a mother has already any pre-existing medical conditions, like if she is already a chronic hypertensive, or if she has already a renal disease, or at the time of booking she has significant proteinuria, again she is likely or at risk of developing this condition. And of course if she has a pre-existing diabetes mellitus, again pre-eclampsia tends to be more common in these cases. So this is the important previous the past medical history that we need to always elicit. And also the other risk markers are if the mother has a low birth weight, or else if she had a preterm delivery herself, again it is considered to be a risk marker. And if she inherits any thrombophilias, that is heritable thrombophilias, again the development of preeclampsia is high. And also if her triglycerides are high in pre-pregnancy period or before conception, again the risk of developing preeclampsia will be high. And also if she is a non-smoker, it's a risk marker. So it usually said that smoking usually prevents this complication. And of course usage of cocaine or methamphetamine use is associated with increased risk. And the other important risk factor is a previous history of miscarriage, and that too if it is less than or equal to 10 weeks with the same partner. So again she is likely to develop this condition in the present pregnancy. So in the past medical history, so previous history of either hypertension or diabetes or renal disease is important, and in the obstetric history, so always inquire whether she had previous episode of pre-eclampsia or whether she is a known case of antiphospholipid antibody syndrome, and whether she had any miscarriage at less than 10 weeks with the same partner. So this is the history that we should always try to elicit. And in the current pregnancy, if it is again a multiple pregnancy, so in multiple pregnancies or in women who have multiple pregnancies, the development of preeclampsia tends to be a bit high. And if the mother is overweight or obese herself, and if it is a first pregnancy, so the likelihood of developing this condition is high. And if she has a new partner also, and short duration of sexual relationship with the current partner, so the shorter the duration for conception, the risk of developing this condition is high. And also in pregnancies resulting from reproductive technologies, so any of the ARTs, again this tends to be high. And also if the inter-pregnancy interval is equal to or more than 10 years, and of course at the booking visit, if her blood pressure is more than or equal to 130 and the diastolic blood pressure is equal to or more than 80, again the likelihood of developing this condition is high. And also in cases where if she experiences vaginal bleeding in early pregnancy, and also of course we very well know that in gestational trophoblastic disease, we see early onset pre-eclampsia, and the two usually this pre-eclampsia is seen even before 20 weeks in cases of gestational trophoblastic disease. And also if a woman has abnormal kappa A or free beta HCG, so high levels of these levels also might increase the risk of this condition. So all these factors in the first trimester increases the risk of this condition. So if a mother is harboring a multiple pregnancy, or if she is an obese woman, and if it is a first pregnancy, and if this pregnancy is because of a new partner, and also if she takes less time for conception, and if the pregnancy is a result of ARTs, and if the inter-pregnancy interval is more than 10 years, or at the time of booking she has a bit of high values in the blood pressures, or else if she has a vaginal bleeding in the early pregnancy, or if it is a molar pregnancy, or else if you do these markers, if Papa A or free beta HCG are high. So these are the factors or the risk markers for preeclampsia. And coming to the second or third trimester, of course, gestation, few of the cases of gestational hypertension might progress to preeclampsia. And of course, the alteration in any of these values like alpha-fetoprotein, HCG, or inhibin A or estriol. And if a woman has or develops excessive weight, so if we see that there is excessive weight gain in pregnancy, so again this is also considered to be a risk marker. And also few of the infections that we see during pregnancy, like especially the UTIs, or if a woman has or develops periodontal disease, again these are risk markers. And of course we find the abnormal uterine artery in cases of this condition, because there is alteration in the resistance of this fluids. So abnormal uterine artery is also a risk marker. And we find various lab markers also to be altered in these cases. So all these are considered to be risk markers for developing or development of this pre-eclampsia. So remember, so it is the maternal age, the family history of pre-eclampsia and the family history of early onset cardiovascular disease, and we need to know what past medical history we need to elicit, and even in the obstetric history what are the things that we see in the previous pregnancies and in the current pregnancy. So we need to always see whether she has any risk markers in the first trimester, either in the form of vaginal bleeding in the early weeks and various other factors. And also a few of the cases of gestation hypertension might progress to preeclampsia. And if there is excessive weight gain also, we need to always think that she might develop preeclampsia, and few of the infections. So all these are considered to be the risk markers for preeclampsia. So why we are worried about this condition? Because preeclampsia is associated with various adverse conditions and severe complications. So almost all organ systems are affected because this is a multi-system disease. So having seen or done with the etiology, so we move on to the various complications. So the adverse conditions and the severe complications that we see with this condition. So in the central nervous system, so the adverse conditions being headache and visual symptoms, and the severe complications that we encounter are the most common complication being the eclampsia or the PRES, that is the posterior reversible encephalopathy syndrome, and few of the women might have even cortical blindness, or the blindness could be because of retinal detachment as well. And the Glasgow coma scale will be less than 30, and few of the patients may also present to us with either stroke or transient ischemic attacks or range that is reversible neurological deficits. So these will be your severe complications of the central nervous system. But the most common complication, remember, it is eclampsia, or very rarely maybe with PRES or sometimes cortical blindness or retinal detachment, or with transient ischemic attacks or stroke or reversible neurological deficits. And coming to the cardiorespiratory complications, so most often they present to us with chest pain or dyspnea, or the oxygen saturation being less than 97%. So the severe complications will be mostly it is uncontrolled severe hypertension, the oxygen saturations tend to fall, and they might have myocardial ischemia or infarctions, and even pulmonary edema is one of the complications. So when it comes to cardiorespiratory complications, so it is either pulmonary edema and needing positive inotropic support, and there can be myocardial ischemia or infarction. And hematological complications, so the adverse conditions or the elevated WBC count, or the elevated INR, or the APTT values, or the platelet counts will be less, and usually it results in thrombocytopenia and the Trondheim syndrome. So in the renal system, so there can be acute kidney injury, and a few of the patients might even require dialysis. And moving to the liver involvement or the liver complications, so most often these women, once the liver is involved, they complain of nausea or vomiting or right upper quadrant pain or epigastric pain, and their transaminases tend to be elevated, the bilirubin will be elevated. So one of the complications will be hepatic dysfunction, or sometimes even it can result in a liver rupture or liver hematomas. So these are the complications seen with the liver. And when it comes to the fetal complications, so the fetal-placental system is involved. So it usually manifests in the form of non-reassuring fetal heart rate, or a fetal growth restricted baby, or oligohydramnias. And when we do Doppler velocimetry, we find changes in the waveform. So there can be absent or sometimes even a reversed end-diastolic flow. So the severe complications will be in the form of abruptio placenta, and you know very well the complications of abruptio placenta. So it can lead to hypoxia and fetal death. So these are the severe complications that we see with the fetal-placental system. So I repeat, So the various complications that we see with pre-eclampsia or CNS, eclampsia, press, cortical blindness or retinal detachment, sometimes coma, stroke or transient ischemic attacks or faint. And cardiorespiratory complications, so mostly in the form of pulmonary edema and myocardial ischemia or infarction. So usually these complications are seen in uncontrolled severe hypertension. So most often when the woman needs more than 3 antihypertensive agents. So these are the kind of women who develop these kind of complications, especially the cardiorespiratory complications. And hematological, we find that they may go into thrombocytopenia and HELLP syndrome, and renal, few of the patients might go into acute kidney injury needing even dialysis. And sometimes even liver is involved, causing hepatic dysfunction, causing increase in various liver function tests, and rarely, very rarely, we may even see a hepatic hematoma or even a liver rupture. And coming to the fetal-placental complications, so it can be in the form of altered fetal heart rates, or it can be in the form of fetal growth restricted baby oligohydramnias, and abnormal changes in the Doppler velocimetry. And at other end, we see a blood sugar placenta and its complications, sometimes leading even to a stillbirth. So coming to the pathophysiology, so what usually why we see all these adverse conditions and the severe complications. So what is the pathophysiology behind this? So in the cardiovascular system, so we find there is an increased peripheral resistance leading to generalized vasospasm and hypertension. So the intravascular compartment is reduced. So that is, there is hemo concentration in this condition, and you very well know that there is an endothelial damage. So significant vascular damage or the endothelial damage, so leading to increased vascular permeability. That is what we said, that there is leaky capillaries. So the extensive endothelial damage leads to increased vascular permeability and hence edema. And all these changes are accompanied by a reduction in central venous and pulmonary wedge pressures. So these are the changes that we see in the cardiovascular system. So basically it is the increased peripheral resistance leading to generalized vasospasm, causing endothelial damage, leading to leaky capillaries and edema, and all these changes are accompanied by a reduction in central venous and pulmonary wedge pressures. And in the hematological system, we find always, not always, we find in few of the cases there is thrombocytopenia. So there is decrease in the platelet number, but an increase in the platelet aggregation and adhesions to the vascular endothelial cells. So the activation of these cells results in the production of both inflammatory as well as oxidative mediators. And also we find in cases of pre-eclampsia, so the levels of antithrombin 3, the protein C and protein S also fall. So it reflects that there is increased consumption of the clotting factors in pre-eclampsia. So these changes are encountered in the hematological system. And when it comes to the liver, so there is vasoconstriction in the hepatic bed, and which leads to the periportal fibrin deposition, hemorrhage and hepatocellular necrosis. So which leads to the elevated liver enzymes, and one of the features of HELLP syndrome is the elevation of your liver enzymes, and very rarely even a hepatic infarction and rupture of the liver capsule, that is Glissen's capsule, can also occur. And coming to the kidney, so there is increased or enhanced vascular sensitivity to the angiotensin II and norepinephrine, so resulting in vasoconstriction and hypertension. And these changes are secondary to the increased bradykinin upregulation. And also in pre-eclampsia, the preglomerular vessels of the renal circulation become extremely sensitive to the vasoconstrictor actions of the angiotensin II. And so usually there is increased or enhanced vascular sensitivity to the angiotensin II and norepinephrine. So because of this, there will be, or the preglomerular vessels will be vasoconstricted, and usually these are the sites where usually the renal synthesis of the nitric oxide or prostacyclin is reduced, or when the thromboxane synthesis is elevated. So this is the pathophysiology that occurs in the kidney in pre-eclampsia. So usually the stages in the renal failure occurs in two stages. In the first stage, so there is impairment of tubular function, so which is manifested by or reflected by a reduction in uric acid clearance, and also the glomerular filtration becomes impaired and proteinuria of intermediate selectivity usually occurs. So this is one of the features of your preeclampsia. And the most characteristic feature that we see in preeclampsia in the renal system is the glomerular endotheliosis. So this is nothing but the swelling of the glomerular endothelial cells and subendothelial fibrinoid deposits which encroach on and occlude the capillary lumen. So because these endothelial cells of the glomerulus become swollen, and also not only swollen, there is also a subendothelial fibrinoid deposits. So together they try to encroach on and try to occlude the capillary lumen. So this is the characteristic feature that we see in preeclampsia in the glomerulus. So coming to the cerebral effects. So why we see various manifestations in the central nervous system. So why do we see eclampsia or ring or stroke? So the thing is, there is cerebral vasoconstriction, so which leads to focal ischemia and abnormal electrical activity. So this abnormal electrical activity manifests in the form of seizures, and also blindness is a rare complication that we see, and it may be either retinal or because of retinal detachment, or it could be because of cortical blindness. So these are the cerebral effects that we see because of the cerebral vasoconstriction leading to focal ischemia and abnormal electrical activity, which is seen in the form of convulsions or seizures or eclampsia. So before we move on to the management part of preeclampsia, so are there any predictive tests, or can this condition be prevented? Because we know few of the risk markers for preeclampsia. So various angiogenic markers or angiogenic factors like pro-angiogenic factors, that is mainly your VEGF, that is the vascular endothelial growth factor and the placental growth factor, and the anti-angiogenic proteins, the soluble endoglin and the SF-1. So these are the things or the angiogenic factors that usually are featured in the development of preeclampsia. And also one of the ways by which we can predict preeclampsia is by doing a uterine artery Doppler velocimetry. So here on the left side you find that there is increased resistance. You find the waveforms to be increased. So there is increased resistance in the uterine Doppler velocimetry that we see in this condition. So this could also predict the development of preeclampsia. And the few of the preventive strategies are there for preeclampsia. So one is prescribing aspirin in the form of 150 milligrams aspirin. So it is said that the 150 milligrams aspirin reduce the occurrence of delivery with preeclampsia before 37 weeks from 4.3% in the placebo group to 1.6% in the aspirin group. So in women who were prescribed 150 milligrams of aspirin daily right from 12 weeks of gestation, so the occurrence of preeclampsia has decreased from 4.3% to 1.6%. So aspirin is said to prevent the occurrence of preeclampsia, especially in women who gives a history of previous preeclampsia. So in women with previous history of preeclampsia, prescribing or giving 150 milligrams of aspirin right from 12 weeks or at least before 16 weeks of gestation lowers the occurrence of preeclampsia in the current pregnancy. So that is one way of preventing preeclampsia in the current pregnancy. And when it comes to anticoagulation, So usually the low molecular weight heparin or unfractionated heparin are not recommended. So again, in women with previous history of preeclampsia, as such, studies do not usually recommend prescription of anticoagulants in the current pregnancy to prevent preeclampsia. And also, calcium is said to be beneficial, especially in women belonging to high-risk population with a low calcium diet. So, calcium is only beneficial in women who have a low calcium diet. Otherwise, in women who have a good calcium diet, this will not be beneficial. So, it is said that calcium is only beneficial in populations where there is low calcium diet. And when it comes to prescription of antioxidants, they say that there is no benefit demonstrated with the use of various antioxidants like vitamin C and E. So among the preventive strategies that we have for preeclampsia, so it is well said that aspirin 150 milligrams is said to lower the occurrence of preeclampsia in women who had a previous history of preeclampsia. And there is no role for anticoagulants, there is no role for antioxidants, and calcium is only benefit or it has a benefit or it has a beneficial effect in women with only a low calcium diet, not otherwise in the women with high calcium diet. So coming to the general measures, so once we encounter this condition or once a woman is diagnosed with preeclampsia, so we need to always admit the patient, and it should be in a quite well lit room, and preferably a one-to-one care should be given, and we need to have charts that include various physiological parameters like your temperature, blood pressure, pulse rate, respiratory rate, oxygen saturations, and also the investigations which I will be dealing. So all these are to be plotted on a chart, and whatever treatment that she receives or whatever antihypertensive that we prescribe should be recorded, and always a large bore intravenous cannula should be cited in these women with preeclampsia because they might go in for an eclampsia. So always we need to cite a large bore intravenous cannula, and if at all she needs an intravenous fluid, it should be well titrated. So coming to the investigation, so having diagnosed this condition, having admitted the patient, so what are the various investigations that these women need and what is their significance? So we need to always do a full blood count, and PCV hematocrit is very important because the hematocrit increased in this condition due to the hemoconcentration. So we very well see the pathophysiology. So usually we find there is hemoconcentration in this condition. So you expect the hematocrit to be raised. And if you do a peripheral smear in this condition, we find there is evidence of microangiopathic hemolytic anemia and also cystocytes. And of course the platelet count, we see in few of the women there is thrombocytopenia because of vasospasm induced microangiopathic hemolysis, and also because of the increased consumption of platelets. So there is thrombocytopenia, and it is less than 1.5 lakh is considered to be thrombocytopenia, and it is also one of the components of your HELP syndrome. And we need to always do or consider a coagulation profile only if the platelet count is abnormal. Otherwise, it should not be a routine part of our investigations in preeclampsia. So only in cases where the platelet count is abnormal, then we should consider doing the coagulation profile. And in the urine, of course, we need to do urine proteins. One is, of course, for the diagnosis of this condition, and also urine microscopy to evaluate for renal diseases. So in the urine analysis, we need to always know whether it is on dipstick, the grade of proteinuria, or else 24-hour urine collection. So if it is more than 0.3 grams, it is significant, and also protein creatinine ratio might also help. So, and in the LFT, we know the liver is also involved in this condition. So we need to always do liver function tests to know whether the liver enzymes are elevated, and even LDH is also elevated in cases where there is excessive hemolysis, and even your bilirubin is also expected to rise in cases where there is hemolysis. So your hemolysis and increased liver enzymes is a part of your HELP syndrome. So hemolytic anemia, elevated liver enzymes and low platelet count forms your HELP syndrome. So we need to always do liver function tests in cases of pre-eclampsia to know whether the transaminases are elevated, your LDH has been elevated, or your bilirubin. And when it comes to the various kidney function tests, so uric acid is increased because of the vasospasm induced renal tubular dysfunction, and also because of the placental ischemia that we see in this condition. So in placental ischemia, there is increased trophoblastic turnover and production of purines, and so that's the reason why we see there is increased uric acid in this condition. So usually it is said that the levels of uric acid correlate with the fetal morbidity. So one of the investigations that we do is estimating levels of uric acid, and of course your urea and electrolytes also should be done. And we need to always do a fundus examination in cases of gestation hypertension and pre-eclampsia and eclampsia, because we find changes in the fundus. So there can be retinal artery spasm or generalized narrowing of your vessels, and there can be altered AV ratio of these vessels, and sometimes in severe cases we might see even retinal hemorrhages, exudates, and extensive arterial changes. And of course papilledema is of course a rare thing that we see really in pre-eclampsia. So these are the changes that we might expect or see in cases of pre-eclampsia once we do a fundus examination. So fundus examination should be part of your investigations. And coming to the fetus, to know the well-being of the fetus, we need to always do an ultrasound. One is to know the estimated fetal weight, and we need to always consider doing serial growth scans to know the size and the growth of the fetus at regular intervals. And because one of the complications or things that we see because of the utero-placental defective utero-placental perfusion is oligohydramnia. So we need to always even look for amniotic fluid index in these cases. And because of the utero-placental changes, we need to always consider doing a Doppler velocimetry to know whether there are any changes in the waveforms. So for the fetus, we need to always do an ultrasound to know the estimated fetal weight, and then we need to consider at regular intervals, every 3 to 4 weeks, we need to do a serial growth scan. We need to even look in ultrasound the amount of amniotic fluid, and of course the Doppler velocimetry to know whether there are any changes. I think I will stop here. We will do with the management of pre-eclampsia and eclampsia and chronic hypertension in the next class, that is tomorrow. Thank you.